Good morning and welcome to today's masterclass on clinical localization of visual loss. So, there are always an eternal questions that happen in that we do ask in neurology. Is there a lesion? If so, where is the lesion? And if the lesion is there, then what kind of a lesion is there? So, before you ask this question, you must ask the history of the patient. Specifically, in history of vision loss, we always ask confirm if there is a visual loss. For that, you have to estimate what is the best corrected visual acuity. What is the advantage of a best corrected visual acuity? It corrects over the refractive errors, any media disturbances. But we should remember, we will not be talking about any media haziness or vision loss caused due to media disturbances due to retinal hemorrhage or uveitis and such and so forth. So, using a best corrected visual acuity will give you a standard point of reference so that you can actually compare the patient's visual acuity today and tomorrow and in the future also. If you don't have access to a good best corrected visual acuity, you can do a bedside test of pinhole testing to estimate if there are rule out any refractive errors. After getting a best corrected visual acuity, you do get the visual fields. As Dr. Basaraj will be telling us later how important are visual fields in localization of the visual loss. We can estimate what kind of disease can be there, specifically looking at what type of visual field defects are there, specifically complete, sectoral, or homonymous visual field loss are there. Color vision is often a neglected part of examination, which could be an early sign of involving optic neuropathies. You do look. It also helps in localization between the retina and the optic nerve. You have red-green dichromatopsia in optic nerve disorders, whereas blue-yellow in retinal. And pupils are very helpful in delineating between the anterior and the posterior visual pathway. You always have to examine the size, shape, and the reactivity and look for an RAPD. Now, when you come to the examination of fundus, I always tell my students that you have to examine 100 normal funduses before you say this is an abnormal fundus. Now, if you look at this patient, we have a 35-year-old migraine with the history of intermittent blurring of vision for 2 years. In the MRI shows a partially empty cella. So would you like to do a CSF in this patient? So when you send these patients to ophthalmologists, they'll tell you that some of these patients might be having a pseudodisc edema. This is an optic nerve drusen. This is an autofluorescence image which shows the drusen coming out. So pseudodisc edema should be distinguished from a papilledema which mediates urgent investigations. This can be seen in optic nerve drusens, tilted optic discs which are very commonly seen, and vitropapillary tractions and types of hematomas. So if you think you've seen 100 funduses and you think you're still very expert, look at this case. You are a 55-year-old male, progressive vision for the last 20 years, family history of vision loss and hearing loss. You think, oh, it's mitochondrial. I'll definitely get a genetic test in this. But you do get an expert opinion in this case. This could be something like a macular or a retinal dystrophy. So you need to talk with your ophthalmologist on and off so that you don't miss such diagnosis. I'm giving you some examples of how to differentiate with clinical science between optic neuropathies, maculopathies, and retinopathies, so that you don't have to, you have to get some ophthalmological evaluation done. So patients present predominantly with graying or shading of the vision fields, specifically in optic neuropathies, whereas in maculopathies, they might present with metamorphosia, or retinopathy will present with photopsia. However, you must remember some patients of optic neuropathies can have photopsia, especially compressive lesions. Vision loss can be more specific for near and far vision is affected in optic neuropathies, but macula specifically involves a near vision. Retinopathy has both. Optic neuropathies has red-green color involvement. Retinopathies has blue-yellow color involvement. The visual fields are very variable in optic neuropathy, but maculopathies involve the central fields. Retina involves peripheral constriction. The most important feature is presence of RAPD. RAPDs are assigned to a non-orphan optic involving optic neuropathy. Unless and until the maculopathy is severe, you won't get an RAPD in any type of maculopathy. So always you have this objective test of BEP and ERGs to differentiate optic neuropathies from maculopathies or retinopathies. So coming into the further details of the neuro-ophthalmological history and while examining vision loss is to localize whether the patient has a monocular vision loss or a binocular vision loss, whether the lesions are transient or permanent. How is the progression? Is it acute, subacute, or chronic? And if there any fluctuation? And always ask for associated symptoms. Even if there is vision loss, you do ask for eye symptoms like diplopia, proptosis, pain, periorbital headaches, or any other neurological symptoms that may help you to localize. So I'll start with the case of a 65-year-old male who comes to the emergency. It's a hypertensive smoker, presents with intermittent blurring of vision in the right eye. You examine him, the fundus is normal, intraocular pressures are 12, everything is normal, so you just send him back with some refrigerator. The patient comes back to you after 1 week with complete loss of vision in the right eye. He has PL negative. This is the fundus image, shows a pale disc edema with flame-shaped hemorrhage. You get an angio done. He has an atherosclerotic plaque, which has actually caused an ischemic optic neuropathy here. So what is a transient? This is a possibility of transient monocular vision. Even the history of how the transient monocular vision loss will help you in localizing various lesions. For example, if you have this altitudinal or lateralized visual field disturbances like a curtain coming down or some field effects, this is all due to a retinal or an optic nerve embolus that happens due to a rupture of a carotid plaque or aortic atheroma or some cardioembolic stroke. If you have diffuse involvement, diffuse graying, if you ask the history properly, if you have diffuse graying, that means there's a global ocular hyperperfusion. This is specifically seen in carotid artery stenosis, where you have more than 75% of the artery being blocked. We have also seen in patients of GCA, and if the orbital ischemic syndrome and or pending CRVOs, in which this transient monocular vision loss will last even up to 30 minutes. So each and every symptom has a localizing value. Sometimes, rarely you get this constricting type of visual fields. They are predominantly seen in choroidal hyperperfusion, sometimes seen in migraine, and rarely in giant cell arteritis. So another type of transient visual loss that we see is a commonly seen, especially in the North Indian population, is an IIH. So this is a 35-year-old female, obese, present with headaches, and intermittent blurring of vision, which worsens on standing up and sudden posture change. Suddenly, she comes with sudden vision loss within 1 day. On examination, you do see she is obese, she has counting fingers, visual acuity, and the fundus shows you complete disc edema with impending pallor. You know this is IIH, she has a raised pressure, the CSF is normal, MRV now rules out a CVT. But you must also ask the history of TVOs. TVOs actually indicate an optic nerve head ischemia that happens in papilledema. Also, this can also be seen in optic nerve drusen and congenitally anomalous optic disc, that is small discs, which are very crowded discs, which are very small and are at risk for developing ischemic optic neuropathies. So the same patient, if I just change a few scenarios, same patient presents with history of headaches for the last 6 months, then to present sudden onset vision loss. Now the same patient, instead of having sluggish pupils, we have normal fundus, normal pupils, but still the patient is having PL negative. You know this patient has a posterior visual pathway defect. So this patient is an RCVS with bilateral severe PCA infarction. So how do you differentiate this as an anterior or posterior visual pathway? You have to differentiate clinically. Anything beyond the LGB, as Dr. Anuja said, is the posterior visual pathway, because this don't involve the pupillary change, and beyond that is the anterior visual pathway. So when you differentiate between anterior and posterior visual pathway defects, laterality has some very important bearing. Most of the anterior visual pathways are unilateral, but it doesn't exclude if it's a bilateral. The severity of visual loss will be much more in the anterior visual pathway compared to the posterior. The associated symptoms that you should always look for, redness, diplopia, proptosis, all these are anterior visual pathway symptoms. And symptoms like cortical vision loss of bumping into object, confabulation, cortical symptoms like dementia, these are all posterior visual pathways. The signs which you can elicit are the specific field effects of relating to the optic nerve dysfunction, central scotomas, and homonymous field effects in posterior visual pathways. Presence of an RAPD almost invariably is a clincher towards an anterior visual pathway defects. So whenever you do get a patient of transient vision loss, don't send them back. Don't send them back. Do work them up. We do have to work them up depending on whether they have unilocular or bilocular or monoocular vision loss. Do evaluate them. They might be having anything from atypical migraine to a life-threatening giant cell arteritis, which can be preventable in most of these patients. So coming on to cases which we routinely see in our practice, We do see like demyelination. This is a 25-year-old female presents with pain in the right eye for 3 days, associated painful eye movements. Then she has blurring of the vision in the right eye. You examine her, she has a right side RAPD, her vision is decreased 6/36. Examine her fundus, you have some disc edema, and the MRI shows right-sided optic nerve is hyperintense. You get a CSF, mildly elevated proteins, OCBs are negative, the NMO antibodies are positive. This is not very difficult to identify and localize. But the issue is, even with these kind of diseases, you are able to localize what kind of where the involvement is. If you have patchy involvement involving a part of the segments, you can say these are all. This can be multiple sclerosis. If you have involvement of the posteriorly extending optic nerve, including the chiasma, this goes more in favor of an NMOST. When you have anteriorly involving bilateral anterior optic nerve involvement, this is nothing but MOB, and including the papilla also, as Dr. Nunoja was saying. So even the type of lesions and location of these lesions will tell you where is the what kind of disease that we are looking at. And the management also differs in these patients. You can't give treatment of multiple sclerosis in NMOST. This can actually worsen like natalizumab and interferons or fingolimod. They can actually worsen diseases in NMOST. So it also helps in diagnosis and management. So when I said don't miss the details, this is the visual fields of the same patients. When Dr. Basavaraj will be talking about the visual fields, whenever I see visual fields, I always look at the visual fields from the patient's perspective. How is the patient seeing? This is the visual field of the same patient. The patient has a right complete vision loss and some superior temporal vision loss. So if you look closely at the MRI, this is the coronal section. As Dr. Anuja was saying, you can see the chiasma better in the coronal section. You can see there's some hyperintensity involving the right anterior chiasma. This visual field is nothing but a junction scotoma. You have this nasal fibers which intonate somewhat into the anterior chiasm and go into. So chiasmal involvement is seen in NMOST, and you always get the visual fields of both. If there's opposite involvement, also do suspect a chiasmal lesion, and this can be more in favor of an NMOST. So when you suspect chiasmal lesion, you should always be wary of the common mimickers. I saw this patient, a young male, present with painless progressive vision loss for over 1 year without any family history, no history of any toxins, and vitamin B12s were low. I saw the pale optic disc. I knew it was Leber, so I got even the mutation done. The next day, I get a call from the surgeon scolding me, why did you send that mutation for a pituitary adenoma? Because I didn't look at these findings of a bilateral temporal aspect of this temporal aspect pallor, which is classically seen in a compressive pituitary lesion. So an MRI is always important to rule out a compressive etiology, no matter how the visual fields are. So if you want to look at how the mitochondrial visual loss looks, it predominantly involves the center of the visual, central scotomas. They don't involve the periphery. Even though others are usually seen, this is a genetically proven case, bilateral thinned out optic nerves, pale disc. So when we come to the cases of anterior visual pathway defects, let me highlight the examples with this patient. She's a patient right now admitted with us. It's a carcinoma breast, post radiotherapy and chemotherapy. Now she has come with asymmetrical sequential onset vision loss, right followed by left, no pain, no diplopia. But on examination, she has this redness in her eyes. Her bilateral eyes are red. You see, and the fundus or angry looking fundus. You don't see this fundus in optic neuritis. She has bilateral CRAO and CRVO. And the MRI shows bilateral optic nerve. And if you look at the coronal section, there's even involvement of the perineural sheath involvement also. So this is an optic neuritis, perineuritis, secondary to an HSV infection. So how do you differentiate between optic neuritis and perineuritis? These are optic perineuritis itself is a very rare disease. It's a predominantly inflammation of the optic nerve sheath. Predominantly occurs in the older population, onset is subacute. You have much more effects of pain and ophthalmoplegia. Either of them were not present, but still presence of congestion was enough to raise or attention. The scotomas in these patients in perineuritis, isolated perineuritis, will have paracentral and arcuate, as compared with optic nerve, which have a central vision loss. MRI will always show you perineural enhancement such as of a tram tack or donut sign, which you can see in optic perineuritis. And if you don't treat these patients with steroids, they'll progressively deteriorate. Even though some of the optic neuritis recover spontaneously within of 2 to 4 weeks. So nowadays the times are changing. Since we have having this pandemic of COVID, we have this is what we're going to see much more often these days. We have 55-year-old male recently detected diabetic, had mild COVID, recovered. Now he presents with 7 days history of pain in the left eye, diplopia, and left eye vision loss. When we examine him, he has complete absence of perception of light in the left eye, frozen eye, proptosis, and there's sensory loss in the V1 and V2. When we look at all this all localizes through the orbital apex and the anterior cavernous sinus involving the V1 and V2. So there we can clinically say this patient has involvement somewhere around here. And lo and behold, this is what we saw. The fundus was showing some those CROs with a cherry red spot. There is ischemic involvement. There is extensive involvement of the left orbital apex, orbit, somewhat going into the cavernous sinus. There is extensive maxillary sinusitis invading into the orbit. And this is the ENT findings when they did a FES. There's a crusting along with fungal hyphae. So this area is predominantly very notorious for involvement of many diseases. Why I'm highlighting the type of diseases that can involve right from inflammatory lesions, from sarcoid malignancies to vascular events, because it's only relies on clinical history and examination and some conjectural evidence of because you'll hardly get to biopsy these lesions in this area. So the clinical localization may not always be easy. In real world scenarios, it might be confusing also, and it might be an overlap of 2 different symptoms. This is a type of case which we see, or which most of us get a call from the gynecology department. Young female, primary, 34-weeker, presents with seizures followed by loss of vision. On examination, she has finger counting close to face. Pupils are sluggishly reacting. You see disc edema with hemorrhages. You see blood pressures 100 or 70 by 100. The patient recovers within a week. But what about this? Patient has disc edema. Patient has some hemorrhages. We know this is nothing but press or eclampsia in this patient. But sometimes you do get confused whether it's an hypertensive retinopathy or papilledema, and the differential and the management changes in both of these patients. You have to get unnecessary tests, CSF done. So you always, apart from the evidence of increased blood pressure, you do look at the fundus pictures. There are some subtle pointers. If you see cortical wall spots or macular stars, they go more in favor of hypertensive retinopathy. Very rarely you get these in papilledema, unless and until they are associated with some other disease like severe anemia. Flame-shaped hemorrhages in papilledema predominantly in and around the disc. Very rarely they go around on the retina. That, as you see in patients of hypertensive retinopathy, they can have even crossing the optic disc, even involving the retina also. And most importantly, most of you should look at venous pulsation. Venous pulsations are typically absent in papilledema. You should have the habit of cultivating looking at the venous pulsations. Whereas in hypertensive retinopathy, you have arterial narrowing. And coming to the second case of how to if there is multiple involvement, here's this case which threw us through our diagnosis, all of us out of the ground. He was an 18-year-old male drug addict, intravenous drug abuser, presents with headache of 1 month and bilateral loss of vision. When we see him, he has no perception of light. Pupils are non-reactive. I see his fundus not so significant. We could make some evidence of macular scarring or old retinitis, old involvement of neuroretinitis. We send them to the ophthalmology department. They say patient has complete necrosis of the inner retinal rear, but that is not enough to explain his vision loss. We get an MRI done. What we see is this delineation of the entire visual axis. You have involvement of bilateral lateral geniculate body causing severe vision loss. This is a disease of the CNS which exclusively targets the visual systems. The patient, when the ophthalmologist saw, they just gave us one diagnosis that this is SSP, and lo and behold, his anti-middle antibodies were positive. So in this era of modern medicine, we have so many high-fi investigations. What is the role of a clinical assessment? I'll show you with this example. We had a 65-year-old female known as a pulmonary TB on ATT, including ethambutol. She presented with painless progressive vision loss. She was treated as ethambutol neuropathy. She was advised to stop ethambutol, but her vision continued to progress. When we saw her fundus was normal, pupillary reactions were normal, but she still had PL9. So we got the MRI done. The MRI just reported multiple tuberculomas here and there, optic nerve and chiasma are normal. So when they sent this report, they never told us where these tuberculomas were present. When we asked our radiologist, they said the tuberculomas are here, exactly pinpointing along the occipital poles. So this critical location of this can cause significant vision loss. So this is what helps in localizing. Clinical examination never gets old, even after 100 years also. So when you see a cortical damage, cortical vision loss, pupillary reactions will be intact in the presence of an absent Meniere's reflex. You might get an absent optokinetic nystagmus, and on EEG, you might even also get an loss of alpha. This is a patient who presents with sudden onset vision loss in the left eye. When we get this visual fields, the patient complains, "I'm not able to see a sector in this video, and the sector below is completely black and white. On the other half of the field, I'm able to see completely normal." So these are the visual. Then why is this patient not able to see colors? So for that, we have to look at the involvement of the cortical visual pathways. As Dr. Anuja already told, the downstream pathway is the Watt pathway. It actually recognizes the color, depth, shape, orientation, and the presence of fusiform face area and visual word form area. They localize words and faces. So any involvement of these can lead to agnosias, hemichromoptasias, prosopagnosias, and alexia. So this is a basic roundup of how the involvement of higher cortical functions. It will be dealt in a separate class later this month. So you can see there is bilateral representation both on right and left for place, face, shape. But face is much more involved, much more represented on the non-dominant side. And on the dominant side, you have the word form area. So if you have any lesion on the dominant aspect involving the word form area, you get what you call as a classical alexia with agraphia, and with the present involvement of the corpus callosum also. So this is a 41-year-old male case of glioma, presents with history of inability to read for the last 1 month. You can still write and identify objects. You can see he has a right hemianopia with localizes to the left side of the visual axis. And this alexia without agraphia predominantly involves the visual word form area and the classical disconnect syndrome because of the involvement of the corpus callosum. So when we just looked at the what pathway, now we look at the where pathway. This usually helps in visual guided actions of perception or perception of motions. Involvement of this area leads to a classical syndrome called a balance syndrome, which is a triad of oculomotor apraxia, optic ataxia, and simultagnosia. This is a case of progressive cognitive decline with history of decreased visual acuity, bumping into objects. The visual field, she has very poor visual acuity, fundus and pupils are normal. So obviously there's a associated cortical signs. There's a posterior visual pathway. She has alexia, calculea, finger, classical of Gerstmann's, and triad of balance also. So this is nothing but a posterior cortical variant of the Alzheimer's. So when you do all this and you still are not able to localize, and in this era of COVID pandemics, lockdowns, you might even get functional vision loss nowadays. So this is a better term would be to use a medically unexplained vision loss. This always never excludes diagnosis of exclusion. You might have to suspect it earlier also to avoid unnecessary tests. You get a positive test, only then you decide then it's a functional vision loss. It can be psychological, or it can, some authorities also believe, dysregulation of the cerebral modulation pathways. So when you have this can either be said with identified either visual acuity due to uncertain visual acuity loss or visual field loss. You have to do all your clinical examination tests, that is use of pinhole, RIPDs, presence of envelope charting, visual field testing, and then you have to get the specific tests done. There are multiple specific tests that are available for testing functional vision loss, testing of the reflexes, using of prisms, using of behavior, blink reflexes, pupillary reactions, or convergence test, depending on what kind of visual impairment is the patient complaining. And also nowadays you have this objective testing of VEPs or ERGs and optokinetic nystagmus testing. So I like to conclude this slide by saying that still now the clinical examination is always paramount. Visual loss can have multiple localizations. It's not unusual for you have 2 or 3 different localizations. If in doubt, you always go back and review. And the most important thing is you'd always discuss with your colleagues. A neuro-ophthalmologist is only as good as the ophthalmologist and the radiologist sitting along with them. I still remember none of these cases were diagnosed by me or my team alone. We had to wait outside Dr. Basaraj's room, we had to wait outside the radiologist's room multiple times to discuss with them. So it's important that you discuss with your colleagues